later. So this the first two groups for our practice session next week will be the last two from Family CA. So group 1 and 2 will be from Silo to Bilog, Nohara to Santos. Tapos yun ay mga susunod na groups. I also uploaded in Moodle already the case protocol and the checklist. Here your score sheet for this practice session. So for this afternoon, we will be discussing, or I will give you a lecture on dealing with a difficult patient. I think we are almost complete. Let me start. So dealing with the difficult. Okay. So dealing with a difficult patient. At the end of the session, the learners must be able to identify patient needs, identify different types of patients, enumerate the components of difficult encounters, identify the difficult patient, and apply the HEAT method in dealing with difficult patients or difficult encounters. Patients visit the doctor because they have needs. They have a personal need and a practical need. Personal needs are to be recognized, to be treated with respect, and to feel important. These needs are addressed by the doctor, who will practice proper attending skills and establish good rapport. Practical needs refer to the specialized knowledge and medical expertise of the doctor, the ability to engage patients and educate them so they understand the disease and the required management, while also considering biopsychosocial issues that may affect management, are important skills of an excellent patient-centered physician. There are different types of patients. So you will encounter the satisfied patient and the unsatisfied patients. So you have your satisfied praisers and patrons and unsatisfied talkers and walkers. Praisers are satisfied patients who let you know just how content they are with you. They are the most rewarding type of patients because they make you feel that you made a difference in their lives. Patrons are also satisfied, but they are rarely open about it. Okay? They are the most satisfying types of patients because even if they don't say anything, you can actually feel how they appreciate you. So they would either send you gifts or they would refer family members or friends to you. Okay, so that's how they show their appreciation. Your unsatisfied patients are your talkers and your walkers. The talkers, they're not satisfied and they will tell you about it. They will give you the greatest opportunity to exceed their expectations because you know what's going on, you know what's wrong. You will be able to make it up to them. Your walkers, they're not satisfied and they will not tell you about it. They just walk away or they just become lost to follow up. They're the biggest challenge because you don't know, what went wrong, what happened, and you can't make it up to them because you don't know exactly what took place or why they became unsatisfied. As much as 15% of patient-physician encounters are labeled as difficult by physicians. Identified components of difficult clinical encounters are situational issues, physician characteristics, and patient characteristics. Situational factors include language issues, literacy issues, diverse cultures, religious issues, and gender issues. So differences in beliefs may lead to misunderstandings and miscommunications. You may not be culturally competent, but you should always be culturally sensitive. Being sensitive to the limitations of others and to individual beliefs and ideations are key to avoiding difficult situational encounters. Other situational encounters may be provoked by having multiple people in the exam room. So this can be avoided by limiting people to those or only to those who are important, needed, or wanted by the patient. So you must limit your staff to those with important roles. So if your nurse or your nurse aide can step out of the room or they're not needed during the consult, then you can ask them to step out of the room. Okay. Among family members or among those with the patient, it is important to identify the important people involved in the care of the patient. So the significant people in the lives of the patient, in the life of the patient. Okay? Always honor what is in the best interest of the patient given the situation. Other identified situations are breaking bad news and environmental issues. Causing distress in another person causes distress in ourselves. So, breaking bad news is something that we need to do as physicians, but this should no longer be a problem for you because you already know your spikes. So, breaking bad news, as much as it causes distress and can cause difficult encounters, you can address that by doing your proper spikes. Granted, of course, you do not forget how to do it. Environmental issues such as noise, chaos, lack of privacy are common triggers for difficult encounters. Situations like these are more likely to elicit unhappiness or displeasure, not only for the patient, but also for the providers and staff. So if you feel that it's too noisy, it's too chaotic, you would expect also that clients or patients would be unhappy or feel unpleasant as well. So having a comfortable clinic or a comfortable environment will help diffuse any difficult encounter. Not all difficult encounters can be blamed on situational factors, nor just to patient factors. The other identified component of difficult clinical encounters are your physician characteristics. Being overworked, sleep deprived, and generally busier than one wants to be are usually what happens to the overcommitted and high achieving doctor. These are also common occurrences seen among government employed physicians and most resident physicians. They end up fatigued and harassed and are more likely to react negatively to patients. Feeling fatigued and harassed can be prevented by learning how to diplomatically say no when you are already overwhelmed and to know your limits. You should also learn how to delegate. So you can't just say yes to everything that someone asks you to do. Okay? And you should know when you've reached your limit and you actually need help already with the tasks that were given to you. Burnout, stress, and frustration can make a person angry and defensive. So, factors that may lead to these are being unhappy with the job or being unhappy with what you're doing, maybe from poor compensation, feeling unappreciated, or not being acknowledged properly. They may also come from personal baggages or triggered personal issues. Identified sources of stress in a study on physician burnout are hunger, anger, being late, being lonely, being tired, and being scared. So, most physicians that they interviewed identified these factors as their sources of stress. So, these are the most common sources of stress. So, when they don't have time to eat or they're too busy that they don't have time to eat, when they become angry or frustrated, maybe because of the long hours that they have, maybe from not being able to do things that they want to do or not being able to take care of personal um, personal things, no? When they become late or they need to finish something and they are late, when they get left behind. So most doctors know and have this problem, especially you guys actually know while we are still training to become doctors, there are times when you have family outings, when you miss out on parties or special events, because you have an exam, because you are on duty. So that uh, gives them, or they see it as something that makes them lonely, and it's a cause of stress for some of the doctors who were interviewed. Being tired because of all the tasks they required of them, and being scared that they are not doing the right thing, scared that they are not doing right by the patient, or scared because they don't know what to do. This table shows different physician factors that lead to stress and difficult encounters. Self-awareness is important not only for successful patient encounters, but to prevent physician burnout. So you should know when, again, no, you've reached your limit, when you've had enough, and you need help already. Okay. Being stressed from inadequate or the feeling of inadequate training or the lack of skills can be addressed by stepping up, reading some more, or asking someone to help you out. Then you have your dogmatic or arrogant physician. So this is the kind of physician who is rigid, inflexible, assertive, basically arrogant. They have overemphasized personal beliefs, values, and emotions, and these strong personal ideas are imposed on patients. With when you are arrogant or dogmatic, it hinders assessment of your patients without bias. It may disempower your patients and prevent them from sharing information about their care. So it prevents openness in sharing of important information and will always lead to problematic encounters. Stress, fatigue, burnout, personal and work-related issues, dogmatic or arrogant attitudes, the lack of skills, lack of empathy, inadequate knowledge, poor attitude. These are all identified factors that inhibit communication and spark difficult encounters. Breakdown in communication between physicians and patients lead to patient anger, dissatisfaction, and also end in possible litigation. So medico-legal suits can ensue if you do not have the proper rapport, no, or the if you have miscommunications with your patients. Finally, we have patient characteristics as the cause of difficult clinical encounters. So the angry, defensive, frightened, or resistant patient, the manipulative, somatizing, and grieving patient, and the frequent flyers are your usual patient characters, those who are involved in difficult encounters. Other patient factors that can lead to difficult encounters, if they have behavioral issues, if they have significant medical issues or health conditions, including past or present trauma, underlying psychiatric diagnosis, and low literacy. So some patients who are labeled as difficult may actually have psychiatric conditions or may actually meet the Diagnostic and Statistical Manual of Mental Disorders criteria for mood disorder, anxiety disorder, borderline personality disorders. So they are difficult not because of any other reason, but because they have an underlying psychiatric condition. And how do we see them? Okay, so we mentioned the patient characteristics, but these are the common labels for our patients. So we have the angry patient, the bully, the internet expert, the silent type, the seekers of truth, the anxious patient, and the non-compliant patient. So your angry patient, Okay, they may be angry because they are frustrated. They get angry because they're irritable, because they're demanding, they're defensive, they're frightened, they're resistant, or they're anxious. So sometimes the presentation that you see is that of anger, but behind that anger are different emotions. How do you know that they're angry? Right? So they come to you with clenched fists, furrowed brows, wringing of the hands, restricted breathing patterns, or maybe warnings, from your staff that your patient, you have a patient who is angry or waiting and very angry already. The bully. Okay, these are your manipulative, demanding, and feeling entitled patients. Okay, so these are patients who want something done and wants it now. They would demand investigations, they would demand for treatment or referrals, and they use guilt. They threaten with rage, legal action, or suicide to get what they want. They exhibit impulsive behavior directed at obtaining, what they want. Some of these manipulative patients actually have underlying psychiatric problems like your borderline personality disorder. The internet experts, so we have a lot of these nowadays. Okay, so these are patients who would come to you with printouts. Oh, yun, extreme na yun. Okay, they would have printouts of either complex or marginal information about their problem taken from a website. But mostly you have patients who tell you that they've read about it, on the internet, or they've Googled all the information that they're telling you, and they fear, that they have that illness that which they Googled. They would demand for unnecessary medical tests or treatments based on what they find on the net. Okay? Some of these patients would also compare what they have to a friend's or a relative's experience. The somatizing patient or the seeker. These are patients who present with chronic, multiple, vague, or exaggerated symptoms. These are your doctor shoppers. Okay, so um, they've undergone so many tests already. They've seen so many subspecialists, but nobody can pinpoint what's actually happening to the patient. Okay. However, diba, we've learned from our um, violence, diba, our domestic violence and our family dysfunction lectures, that most of these somatizing patients have actually underlying psychosocial problems. Okay, so your somatizing patients may actually be victims of abuse. Okay, they may actually have dysfunctional families. Okay, and they the symptoms or their frequent somatizing, are um, imply, that they are going through, a difficult time, or they have all these problems. And you have your anxious patients. So they are upset, nervous, distracted, and uncomfortable. So your anxiety is provoked by having a chronic illness, actually, realistically having a life-threatening illness, or maybe because they have prolonged and uncontrolled symptoms. Their anxiety may come from previous experiences, either their own experiences or experiences from family or friends, okay, or previous trauma. Lastly, you have your non-compliant patients. So these are your patients who don't take their medications as prescribed or don't follow, the prescribed course of treatment. Some of them would continuously fail to follow up or miss scheduled appointments. Okay, so they become difficult patients because cannot you cannot treat them properly because they don't follow what your advice. So as I mentioned already, so na-repeat lang yung slide, a considerable number of patients who are labeled difficult, are actually psychiatric or actually have psychiatric conditions. So how do you manage these difficult patients? The first step, the most important actually, is to do your CEA. So you listen, you listen to their concerns, you listen to their issues, and you find out if there are emotionally critical misperceptions that are behind their behaviors, no, behind their feelings, or behind the difficult encounter. So maybe they don't understand something, or they have misperceptions, which leads to inappropriate behaviors and difficult encounters. Prompt assessment, no, and referral for possible psychiatric conditions should also be done. And finally, we have the HEAT method. Okay, so one way of dealing with difficult patients or difficult encounters is to use your HEAT method. HEAT stands for hear them out, empathize, apologize or acknowledge, and take responsibility for your actions. Very important before you do your HEAT, you must first shed light on the situation. So whether your patient is obviously upset or seemingly upset, no, your uh, non-verbals, no, show that they are upset. No, you know that there's something wrong, and you want to uh, discover what's going on. If you don't look into what's wrong, you will never get anywhere with this patient. Okay, so you're wondering, no, why they have these emotions, why they are that way. Okay, you have to investigate. So you start with statements like, "You sound like or you really look upset. Can you tell me what is wrong?" Or, "You seem to be cross about something. Can you tell me more about this?" Okay, "Tell me about," or, "You were very angry with the nurse. Why was that?" Or, "Can you describe the situation in more detail?" Okay, when you ask these questions, you're actually clarifying, what's happening. So you observe, or you hear your patient complaining, or you observe something from your patient and you want to know what's going on. Okay, so you want your patient to tell you more about what is happening. So you make use of your very handy and well learned communication tool, your active listening skills. Okay, so know what is going on. Get your patient to tell you more about what is happening. So you use your leading skills, your probing skills, your reflection skills, your summary, and you're checking for understanding. Okay? Once you know what's going on, so they've actually already started talking about what's going on or what is wrong, then of course your next what you should do is to listen to what they have to say. So hear them out. While hearing them out, you're allowing the person to ventilate. Okay, so you allow them to ventilate without any interruption. So let them talk, encourage them to speak. So use your active listening skills for them to open up. And while they are talking, identify for any possible emotionally critical misperceptions that are causing the behavior. Once they have ventilated and they have narrated everything, or they've told you everything that's happening to them, the next step is to empathize. Okay? So you may use words like, "It must be frustrating or upsetting. I can understand why you feel that way. I see what you mean. I think I can see where you are coming from. Let me see if I got this straight." And then you try to summarize what he just said. Okay, so they have exhausted their thoughts, emotions, and now you have a better idea of what is happening or what is causing that emotional moment. Okay? In empathizing, you're trying to put yourself in that other person's shoes. So if you were in the same situation, would you feel the same way or would you act the same way? When you empathize, you are validating the experience and the negative feelings. Okay, so based on your explanation of what happened, it seems that or your feelings of anger is reasonable because or your anxiety may have some bearing or I would feel sad as well, based on what you just told me. I would have exactly the same feeling. When you empathize, it's not the same as agreeing. So it's just putting yourself. Now, if you were thinking that way, if you were feeling that way, maybe this is the actual reaction that you would have to. Okay? So once you've empathized, the next step is to either apologize or acknowledge. Okay, so um, if your staff or you have something to do had something to do with the difficult encounter, then you apologize for what happened. Okay, but no, if you had nothing to do with directly or you're not directly the cause of the problem, you may want to just acknowledge at least know that the patient went through something or the patient took things the wrong way. Okay, so you may want to say, I'm sorry you were inconvenienced. I apologize for the situation. I'm sorry it didn't meet your expectation, or I'm sorry you feel this way, or I'm sorry that you are having these problems. Before you apologize or acknowledge a problem, you have to know exactly why you are doing them. Okay? So do not apologize for the sake of apologizing and avoid defensive explanations or responses. When you apologize and you acknowledge, you want to provide information that the patient desires based on the issues and concerns that he or she raised while she was ventilating. Okay, or based on, or you may want to explain things based on rules and protocols. Okay, so it's not enough to just say, I'm sorry. You have to know what you are sorry for. You have to know what the issue really is, and you address that particular issue. And the only way that you would know what the patient's issue is, is to elicit it from them. Okay, so when you let them ventilate, when you tell them to tell you more about what happened, that's the time that you look into the issues and concerns. And that's what you apologize for, or that is what you acknowledge. Okay? So after apologizing or acknowledging, you take responsibility. Okay? So I'd like to take, you may give statements like, I'd like to take care of this right away, or let's talk about how we can correct the situation, or I'll do what I can to remedy the situation. In taking responsibility, you may choose to meet or exceed the need. So for routine situations, just act promptly and courteously. So just meet the need. For non-routine situations, you may want to agree on a clear course of action or take it a step higher. Okay, you want to exceed the need, so you put an extra something, so to please the person. Okay, but make sure, that when you exceed the need, you're able to follow through. Okay, you can't exceed the need tapos hindi mo pala siya magagawa. Okay, so it is best to take opportunities to exceed expectations when possible. Okay, but is it doable? Can it really be done? Okay, so you must set your boundaries and explain your actions or decisions clearly so that it will not be an additional distress for the patient. Okay? Sometimes just talking about it, just letting them say what they want and acknowledging, that there something happened or something went wrong. Sometimes that upset person just wants that. They just want to be heard. They just want to be acknowledged, and no action naman is necessary. Okay, so you just hear them out, and that would be it. But for some, of course, they would want something or an action to be done. Okay, in meeting or exceeding the need, so you can tell them, no, what would you like me to do to help you? Or you can just tell them, I'll take care of this right away. If requests cannot be done, You can say, what I'll do is this. Is that okay for you? Or you may say, another thing we can do is this. Okay? Or this is what we can do. Would this be okay? Or do you have any other suggestions? Okay, so you're trying to solve the issue. You're trying to take care of what took place, of the concerns. Okay. As with all patient encounters, we always end by confirming satisfaction. So ask questions to confirm satisfaction. So is there anything else I can do for you? Is that satisfactory? Does that take care of everything? Or if you have any other questions, please feel free to call me. Please feel free to drop by again. Okay. In confirming satisfaction, you should always commit to follow through if appropriate and always thank the patient. Always know what exactly is going on and what went wrong. Okay, so through your active listening skills, through your catharsis, you will get to know what really went on. Aimlessly defending yourself or the person who upset, the upset person or the angry patient, will just add fuel into the fire. And you will end up with more hurt feelings and longer delays in the conversation. Okay, so I have a short video. It's a different. Maybe I should show that pa rin. It's called the Universal Upset Patient Protocol, but it's just a different version of HEAT. Okay, so it shows 6 steps, but if you consider the steps, so they also show yung clarifying the situation, hearing them out, empathizing, apologizing, acknowledgement, taking responsibility, and confirming satisfaction. So let me play that. Okay. So any questions so far? I uploaded that Universal Upset Patient Protocol. It's very similar. It's a different version of your HEAT, as shown in that last slide. They have the same steps. Medyo mas marami lang yun dun sa Universal Upset Patient Protocol, but basically the same steps. Any questions so far before I show you that Universal Upset Patient Protocol? Questions? Okay, sige. So let me play that other.
When was the last time you had a difficult interaction with an angry or upset patient? You felt ambushed, didn't know what to do or say, it did not go well, and you felt bad for days. This is Dr. Dyke Drummond at thehappymd.com, and in this short video I'm going to show you a way to deal with angry and upset patients quickly, efficiently, effectively, empathetically, and get on with your office day and home on time. I call it the Universal Upset Person Protocol. See, most of us don't get any training on how to deal with emotionally upset or angry patients, so we do what comes naturally. We either try to fix their problem, or we try to defend ourselves or whatever the upset person is upset about. And that's just about as effective as throwing gas on a fire. Here's why. See, in an ordinary office visit where the patient's not upset, you can talk about what brought them in. But if they're upset, if there's a lot of emotion in the room, it's feelings first. They simply have to share their feelings and feel understood and listened to before they can go any farther. Teddy Roosevelt once said, "People don't care how much you know until they know how much you care." It's exactly like that. And the Universal Upset Person Protocol is the quickest way to give the patient a safe place to vent their feelings, share them with you, you to listen so you can wrap it up and move into the clinical part of your office visit. Let me take you through the 6 steps of the protocol real quickly here in an overview, and then we'll go into them in more depth in just a minute. And just so you know, down below the video frame here is a handout that gives you a full training, including all the statements and questions in the protocol. Make sure you get that before you're done here today. Here are the 6 steps. Number 1, you look really upset. Number 2, tell me about it. Number 3, I'm so sorry that this is happening to you. Number 4, what would you like me to do to help you? Number 5, here's what I'd like us to do next. Number 6, thank you so much for sharing your feelings with me. It's really important that we understand each other completely. Thank you. Now let's drop down and go through those one at a time. Upset patients come in 2 flavors usually. One, they're obvious and they're verbal. You can hear them coming down the hallway. Second type are quiet and seething. They don't speak, but everybody knows they're upset. Either way, if you notice this, you're not going anywhere till they clear these emotions. So your first statement is, you look really upset. You'll typically get one of 2 responses. You bet I am is one, and the second one is, I'm not upset, I'm frustrated. Or they may name some other emotion like that. Now there's a piece inside of you that may feel bad. You may feel like you got it wrong. You can let that go. Your observation has caused them to look inside and get clear on what they're really feeling. That's the first thing they have to do, so great job. Here's step number 2. Tell me about it. What you've done here is given them a green light to tell you their experience, and your job is to listen. To understand what they're going through and make sure they notice that you're listening. They feel heard. And here's step number 3. No matter what's happened, you can apologize. I'm so sorry that you're feeling this way. I'm so sorry this is happening to you. Let them know that you have sympathy for their situation. Critically important to maintaining your bond with this patient. Here's the next step. What would you like me to do to help you? And here again, you've got to listen. And as you're listening this time, notice your boundaries. Notice things that the patient may request that you're not comfortable with. Next step, when they're done, take a pause, think about what you're willing to do, and tell them, here's what I'm willing to do going forward. Here's what I suggest. Here's a plan I recommend. And any time that you are not giving them something they've requested, tell them what you are going to do instead. And last, to wrap this difficult encounter up in a way that builds your relationship for the long term, thank them for being willing to share their feelings with you. Let them know how important it is that you each understand each other clearly. Well, there you go, 6 steps to the Universal Upset Person Protocol. And this works with anybody who's upset. Your children, your significant other, your colleagues, your staff, random people on the street will respond to you much more positively and go breezing right through their upset when you use the protocol. I know there's 6 steps. However, normally in the office with a normal patient, it'll only take you 2 or 4 minutes to do this. And if you don't, if you instead try to fix their problem or defend yourself, you are going to be in for a 20-minute kerfuffle, and you know the kind of patient interaction I'm talking about. Once again, the handout for this training is right below the video frame. Click.
Okay, so as I've mentioned, I uploaded that video and other videos to give you an idea how to go about the practice session next week. Okay, so I will be posting the groupings in Moodle. We will start with the last 2 groups. Yung nahuling last 2 groups, kayo naman ang una for next week. Okay. Do you have any questions?
None po, Doc.
Okay. Sige. If